Dr. Liu. I'm always amazed how busy he is. He never misses an engagement. He's a real trooper. I'd like to introduce our next speaker. Oh, by the way, I forgot to mention I'm honored that Alan Persinki is here, one of the great sleep doctors in this country, and one of the best doctors in the metropolitan area here. But I'd like to introduce Stacy Fisher, an associate professor of cardiology who is director of the adult congenital heart disease program at the University of Maryland. She came to us from Miami, where she achieved a baccalaureate. She did medical school at the University of Maryland, did a residency in medicine at Duke University, then went to the University of Rochester for a fellowship, and then stayed on at, went to Strong Memorial, where she was senior fellow in cardiology. She has extraordinary experience, and we're very honored to have you here tonight, Stacy. Yeah.
Thank you very much. So Dr. Henderson gave me probably the most challenging topic I've ever had. And I tried to have a little fun with it. I only made about, I think, 18 slides because I wanted to leave room for talking, and I also want to show you one of the fun things that we're working on. How do I go to the next?
Do you have a clicker?
I have this.
It doesn't work. No, sorry. It's one of these.
Okay, thank you. Okay, so I think that the unifying issue is collagen. And collagen is really what we're here to talk about, and it's really the unifying diagnosis in Ehlers-Danlos and many of our connective tissue diseases. And one of the problems is that we don't understand everything about collagen. We understand that there are many, many genes that go into how you make collagen and what collagen types may be normal or abnormal, and there are promoter genes that may turn on those genes or affect those genes, so that one person with the same problem with collagen may have a different manifestation or different severity of the manifestation of the problem than another family member with the same exact gene problem. So we're just learning about all these genes. And my hope for the future is that we actually learn how to work with the collagen to strengthen the collagen, which would affect the arteries, the veins, the muscles, the ligaments, the joints, all of it. So hopefully we're actually going in that direction, either through genetic engineering, genetic discovery, or stem cell research. Because if we could take somebody's own stem cells and modify the gene issue in the weak collagen matrix, then actually we would be able to repair the problem. And you wouldn't need Dr. Liu or me. And actually we would have to find something else to do. That would be great. Exactly. A vacation and then a new project. So, and that would be great. So I'm hoping, I know we're trying to fix veins, we're trying to fix arteries, but I'm really hoping that the bigger picture actually is under discovery now. So I wanted to speak a little bit about collagen and then a few of the things that I see in my practice as a cardiologist that can be affected. So just one proviso, I'm actually an adult congenital heart doctor, so I take care of a lot of birth defects or people that have grown up with irregular structure. And my interest in Ehlers-Danlos came through the Aortic Disease Center that we have, where we work with a lot of patients with either Marfan's or Turner syndrome or Ehlers-Danlos, primarily vascular Ehlers-Danlos and some hypermobility Ehlers-Danlos for screening aortic issues. So the genetic disorders of collagen are many. Some of the ones that would be most pertinent to this group would be things like osteogenesis imperfecta, Ehlers-Danlos and Marfan's, and Loeys-Dietz. And there's a lot of heterogeneity where different types of collagen problems are found, and collagen actually is in all tissues, but different types of collagens makes up different support in different parts of the body. So if we actually can understand which genes are affected, we could actually understand more in an individual which parts of the body might be affected. Is it the eyes? Is it the gums? Is it the heart muscle? You know, what is actually going on so that we can do more proactive care. So collagen in the heart, which is, of course, my interest. Basically, we don't have a lot of information, and we definitely don't have directed therapies. But we know that the collagen diseases affect the heart in different ways, some of which have scarring, where when we do things like a cardiac MRI, we can actually see scar, and that can make you more predisposed to things like heart rhythm problems. So this is one study looking at a different problem, which is patients with hypertrophic cardiomyopathy, a genetic problem of the heart muscle, and looking at the makeup of the collagen and showing that the collagen actually is between the muscle cells and affects the matrix and the coordination of the muscle cells more than the cells themselves. So it's the actual glue that binds the cells together and holds the structure of the heart, which is going to affect not only the squeezing, but the relaxing function of the heart, and also allow people to have more access to arrhythmias. They're less protected from barriers to extra heartbeats, either in the top or the bottom chamber. So I was asked to introduce the idea of diastolic dysfunction. Now I have to say, testing for diastolic dysfunction, or the relaxing function of the heart, is fairly limited still in this day and age. We use echocardiography as our primary role. We're starting to use testing that involves strain measurements to look at actually the tension of the muscle as it relaxes. So diastolic dysfunction is an active energy requiring process of heart relaxation and filling. And if you look at the muscle, we're talking about how the muscle relaxes, not how the muscle contracts. So we're looking between the muscles. So if you look at how muscles are lined up, I think I have a pointer here. If you talk about how muscles are lined up, we're looking at the areas between them as well as the matrix that holds the cells together. And we're looking to see how they relax. So I have to say that in a lot of discussions I've had with Dr. Henderson recently, to me, diastolic dysfunction really hasn't been a part of the hypermobile Ehlers-Danlos syndrome, but there are some features of diastolic dysfunction, such as high pressure against the veins, high pressure against the veins in the lungs, things that can make small arterial venous malformations form that may really have a role. And certainly there is a pathogenic mechanism where it could actually affect the way the cells line up together and work together that could cause this role. So this is something that is certainly a lot for thought, and something that we'll be looking closer at on the echocardiograms that we do for screening for aneurysm. So again, the idea of collagen and diastolic dysfunction, this is one article that is helpful in that idea, where the myocardial collagen matrix is an active part of showing the ventricular architecture and diastolic dysfunction. And where does this really matter? Well, it really matters in people who have problems in their collagen. So people who may have risk of things like exposure to something like energy drinks, of people who may have exposure to things like surgery, where we really need to take different precautions than we take for other people. So energy drinks are something I'm also passionate about, because we see a lot of problems in my congenital heart patients with energy drinks. So the first reported death of an energy drink was actually a young girl in Hagerstown who is an Ehlers-Danlos patient. Her mom is very proactive in trying to warn people about the dangers of energy drinks. And on her autopsy by report, again, I didn't see her or know her. This was from her mom, who actually speaks about protecting kids and protecting people with Ehlers-Danlos from risk. She actually had had 2 Monster energy drinks within a 24-hour period. had had a cardiac MRI with normal heart structure and function, and then on her autopsy had some small areas of patchy scarring that they think may have been an area that was able to be triggered to cause arrhythmia secondary to the energy drinks. So energy drinks are not caffeine. They're a lot of ingredients mixed together that are both inotropic and caffeine, so that they make the heart work harder to try to perform better, and they have the caffeine. And we don't really know how those two go together to cause arrhythmias, but there's a lot of concern about arrhythmias in energy drink users and even seizures. So we're just learning to ask that question too. But things like epinephrine, things like standard induction for surgery, it's really important for your doctors to know if you have a collagen vascular disease, just that it's there, so they take some extra precautions. They may choose a different anesthetic. But if they have that information, they can actually make good decisions with you on how to do your care. We're asked a lot about pulse pressure. So this is a really tough question, because we'll hear people say that they feel terrible when their pulse pressure is narrow. And that's actually a very unusual complaint. The pulse pressure, what it is, it's the difference between the systolic and diastolic pressure. So for example, if 120/80 is a normal pressure, and so the difference of 40 between the readings is also considered to be a healthy pressure. So low blood pressure is generally less than 90/60, and a low pulse pressure is generally a difference of less than 25. So most causes of narrow pulse pressure are totally unrelated to anything we would be talking about here. There are more people in cardiogenic shock, where the heart function is very low and they just don't get enough blood flow. So if you just look up a narrow pulse pressure, you're going to read terrible things and terrible mortality. And that is not what applies here. But what may apply here is that the lower narrow pulse pressure can be caused by a drop in the volume of the left ventricular stroke. So the heart just isn't getting as much out as it needs to. And that could either be because the filling volume of the heart is low, everything's pooling, nothing's coming up, and the vessels are dilated, so you don't have enough left in the heart to get a good output. So that could actually give you a low pulse pressure. And this can occur from either neurocardiogenic input, or from vessel laxity, or from a low volume state like bleeding or dehydration. So what do we mean neurocardiogenic? Because that comes up a lot. What is that? And it's really a communication between the brain and the blood vessels. And I think that a lot of the symptoms that come have a lot to do with the communication between the brain and the blood vessels. There is very, very little in the literature to support what happens when, for example, the intracranial pressure is high, what actually happens to the blood pressure and the heart rate and the level of dilation or constriction of the blood vessels. But that's where a lot of people have symptoms, and where a lot of the symptoms get kind of scary, because people really feel that their heart is racing. They get lightheaded, they get low or high blood pressure or significant fluctuations, and people have had syncope or fainting. So a lot of times when people have naturally low blood pressure and then you add another challenge such as changes in intracranial pressure, the brain doesn't like the pressure to be changed, and it sends a storm of discussion out to the vessels and nerves to change the strength of the vessels and nerves, trying to promote pressure up to the brain, trying to preserve its blood flow. And that actually can cause a lot of the changes that we see in the heart rate and blood pressure. So that is one trigger, and something that is because of the regulation of the intracranial pressure. At the same time, there are other changes in autonomic function that are really well studied and well discussed that have similar effects. So for example, testing in hypermobile Ehlers-Danlos patients, one group showed autonomic deregulation with increased sympathetic activity, and we're going to talk about what that means a little bit more, and also reduced sympathetic activity to stimuli. So if you have somebody who basically does something like a Valsalva when you take a deep breath in and bear down very hard. What that does is it changes the filling pressure, and it changes how strong the vessels are as far as how they're dilating or constricting. And you should be able to actually elicit some of the changes in the blood pressure in a very predictable and measurable way. And we're looking at what happens when people do that, when they have other challenges or when they have a reaction that is not the typical reaction that we would expect. And we can learn a lot about what's happening in that person. So one way to do that is with Valsalva testing. One way to do that is with tilt table testing. Tilt table testing was also developed by NASA. It was developed to see who actually doesn't tolerate an introduction to space and the change in gravity. So it's kind of interesting that there's a NASA connection even with the basic testing of this issue. So tilt table testing is actually very straightforward and uncomfortable if it's abnormal. So you have somebody lay flat on a table and get their blood pressure and heart rate and have them on a monitor. Sometimes, usually check their oxygen levels. And then we tilt them at 60 degrees and then 80 degrees. And what that does is gravity not only pulls to your legs and feet, but it pulls all the way to the back, the buttocks, the legs, the thighs. So you get a heightened effect of gravity. And that can trigger pooling, or it can trigger dilation of the vessels or changes in the heart rate that may be an exaggerated response to normal or an abnormal response. So we can actually try to pull out what somebody is feeling and understand the physiology of it. So we're trying to separate anatomy from physiology and see what the neurochemicals in the brain is telling the blood vessels to do. So this is generally done when we have already ascertained that somebody has a normal heart and normal blood vessels by structure, right? Because if we have abnormal heart or blood vessels, we need to deal with those first. So this is a very good way to differentiate things like postural orthostatic tachycardia from vasodepressor syncope from vasovagal syncope. So this is a very helpful process. And it's very clear in hypermobile Ehlers-Danlos patients that many of the patients will actually have changes in the way they respond to these triggers. Keep going the wrong direction. And I'll go through this, but while I'm doing that, actually I'll do this after. So this is, I still want to, do you know where the pointer is?
It doesn't have it.
Oh, okay. So that's why I'm having trouble.
And it's also a touchscreen, so we can.
Okay, so this, oh, thank you. This is a touchscreen?
Yeah.
Okay, so this is your systolic blood pressure. This is your diastolic blood pressure. And the black is the controls, and the blue is patients with hypermobile Ehlers-Danlos syndrome. And you can see what happens. This is 3 minutes upright, 10 minutes upright, 20 minutes upright. And this is what happened in this one study with tilt table testing. So you can see what the heart rate changes compared to controls, and you can see what the blood pressure and therefore the pulse pressure changes compared to controls. So you can see that there really are significant differences, and the pulse pressure can narrow in Ehlers-Danlos patients. And again, what physiologically makes sense and certainly hasn't been proven is that the cardiac output is lower because the heart is filling less when you have these changes. And that's likely why people feel so terrible when they have the narrow pulse pressure. So what is our orthostatic intolerance? It's really the difficulty standing upright. So increased vascular laxity can lead to increased dilation of the vessels and then to orthostatic intolerance. Connective tissue defects can alter the distensibility, extensibility, peristalsis, permeability, and epithelial cells of the gut. Fatigue and pain have generally received attention as possible consequences of dysautonomia. And the orthostatic intolerance, which is one of the hallmarks of dysautonomia, is currently thought to be one of the causative mechanisms of fatigue and brain fog. Both fatigue and impaired concentration are suspected to result from reductions in the cerebral blood flow. Research in this has shown promising results demonstrating that successful treatment reduces fatigue. And if this mechanism is true, then fatigue may be more amenable to treatment than previously thought. So how does this relate to intracranial hypertension? And I really worked hard to relate this because I knew Dr. Liu would be here. And it's clearly related because, again, sometimes if somebody does have intracranial hypertension and has a shunt or a stent, you see that the orthostatic intolerance almost goes away or may be manageable where it wasn't manageable before. It doesn't change the rest of the vessel laxity, but it can actually improve their functionality and allow them to be more treatable than they were in the past. And certainly can allow them to be upright in a lot different ways than they were in the past. This is one study that I thought I would pull out because it's pertinent. It's a study not in Ehlers-Danlos, but in chronic fatigue syndrome. So this study that was elegantly done took patients with chronic fatigue syndrome and they matched them with controls, and they looked at self-reported automatic system profile scores, and patients had much higher levels of orthostatic intolerance. And those patients had symptoms that were associated with lower intracranial compliance and higher resting perfusion. So they actually looked at compliance and perfusion. And in both groups, the compliance in the brain vessels negatively correlated with the cerebral perfusion. So if they had better blood flow, then they had lower compliance. If they had high compliance, it affected the blood flow or vice versa. And again, we still have the chicken and the egg problem here. So the idea is that this may alter the ability of the cerebral vasculature to cope with changes to systemic blood pressure due to orthostatic stress. And again, I don't think it's specific to chronic fatigue syndrome, but it's a very interesting concept, and it's something that really relates to the new technology you're trying to use to understand the venous changes better. So another study, venous collapse regulates intracranial pressure in upright body positions. So again, this goes to the same type of thought process, that a change in the brain and a change in the intracranial pressure or the filling of the brain can stimulate changes in the blood vessels and heart rate where people have orthostatic intolerance. And I think it's a very prevalent and really obvious relationship when you look at patients and what happens. And for some of you that have gone through intracranial stenting, you may have noticed a big difference, or shunting, or had a Chiari repair that relieved the pressure. You may have found that things like orthostatic intolerance became more manageable, maybe not absent, but more manageable. And sometimes it's really important to address those problems first so that you can actually have a manageable problem with the rest of the connective tissue disease. So the autonomic nervous system, adequate blood volume, and intact skeletal and respiratory muscle pumps are essential components for rapid cardiovascular adjustments to upright posture. Orthostatic hypotension is seen in patients lacking sufficient blood volume or having defective sympathetic adrenergic vasoconstriction. Orthostatic hypotension is one form of orthostatic intolerance. Signs like low blood pressure, lightheadedness that occur when you're upright or are relieved by recumbents. Mild orthostatic intolerance is commonly experienced during illnesses and when standing up rapidly by anybody. It can be a normal cardiovascular adjustment to blood volume shifts during standing. So that's actually really important too. Standing is a challenge for all humans. And what goes into the blood vessels to get blood up to the brain and not just have it all sink down when anybody stands is a challenge. And then an exaggerated response to that is a harder challenge. Some people experience episodic acute orthostatic intolerance, and one example is vasovagal syncope, which is a fainting syndrome. or chronic orthostatic intolerance like postural tachycardia syndrome, and those can more significantly reduce the quality of life. 40% of your average people have had a lifetime incidence of one or more fainting spells. So one fainting spell in the right setting, like maybe having a blood draw or being really dehydrated, it doesn't diagnose you with postural tachycardia or orthostatic intolerance. You can be a normal, healthy person and have that. But out of context, when it's happening without those problems and when it's not manageable, that's where it becomes problematic, and that's where the terms and diagnoses can really be helpful in trying to decipher how to treat them. So we look at both the sympathetic and the parasympathetic pathways, where the sympathetic is going to be primary vascular neurotransmitter related, like norepinephrine, and co-transmitters, which make the arteries constrict and the veins constrict. And these increase cardiac contractility and heart rate, stimulate adrenal epinephrine release, and control the neuroendocrine and vascular function of the kidney, and definitely affect long-term blood pressure control. The parasympathetic aspect has more vagal nerve afferents. It contributes mostly to heart rate changes at rates less than the intrinsic rate. And the strong vagal influences affect the sympathetic system, affects nitric oxide containing nerves, and vasodilation of the large cerebral arteries. And then we also look at the interaction with the endocrine and local systems, which impact the vascular milieu, but also are slower to develop, and often act to modulate or set the tonic activity of the autonomic nervous system. So that controls the heart rate and the blood pressure, and also a lot of the control, the autonomic control is provided by baroreflexes. So, So why this all matters is so that we can differentiate types of fainting and types of postural challenges. And then we can look at actually what is the defect, what is the pathophysiology, and then what are some of the options for treatment. So categorizing this and understanding this can make a huge difference in the trials and errors that go with initiating treatment, because the goal isn't just to understand what's going on, it's to provide a better lifestyle and a more functional lifestyle. All of these include hydration, monitoring blood pressure, and obtaining reasonable blood pressure ranges. And again, the goal, because this is structural, isn't that we're going to fix the problem, it's that we're going to moderate the problem so that we get it into a quality of life that is more functional. So the tilt table test can actually be very helpful, where if we look at this, which is actually one of the best articles I've seen from 2013 by Julian Stewart. This is a study done in kids that looks at all types of neurocardiogenic and orthostatic challenges, and goes through very nicely backgrounds of what these are and why they are and how to treat them. And again, really looks at, for example, vasovagal syncope versus postural orthostatic tachycardia, and looks at multiple patients who've had tilt. This is a review article. Sorry, I keep thinking this is a pointer. But looks at time in seconds at when this patient had syncope, showing that with vasovagal syncope or neurodepressor syncope, you usually get syncope. With postural tachycardia, you feel bad, you get very high heart rates, you can get very low blood pressures, but usually you can make up for it and you don't usually get frank syncope. So autonomic regulation and collagen, bringing this back together, it's a complex relationship with some understanding. There's clearly both genetic and neurohormonal influences, and the structural influences like CNS, arterial and venous structure, cardiac reserve, looking at both systolic and diastolic functions, which is the squeezing and the relaxing aspects of heart pumping, and the value of tilt assessment. These are all becoming more integrated, becoming better understood, but they're not done yet. And again, if you look in the literature at what happens with high intracranial pressure and PUTS and how is that related, there isn't anything. It's just not there, and the understanding hasn't been agreed upon, accepted, vetted, described. It really is a brand new world that you all are pioneering in a lot of ways. So I wanted to show you one thing, because again, this is all in the absence of defined structural problems. So when you have a defined structural problem that's inhibiting something else or explains something like orthostatic intolerance or TIAs or foggy thinking, you really do want to address that first. So for example, one patient who came for TIAs, he's actually a young gentleman. He was given a blood pressure pill, a very low dose actually, 5 milligrams of lisinopril for very high blood pressure. And he instantly had a very profound, awful TIA that lasted about 4 hours with left-sided hemiparesis. He was hospitalized. He had extensive assessment. And he had something funny about his physical exam that made me want to get a chest CT. And we found a structural problem, and one of my fun things right now is working on 3D heart printing. So we're trying to use 3D heart printing in our complex hearts to help the surgeon get a better result and for us to better understand exactly what some of these complex anatomies are. For example, the exact distance between two holes that shouldn't be there, or for people with hypertrophic cardiomyopathy, exactly how much muscle needs to be taken out or and how deep that muscle is, trying to minimize side effects of surgery. So in this patient I brought to you, and we'll pass around his arch. So this is made from his MRI scan. And there is software that's commercially available that's difficult to use still, but really fun, where you can even use Google Glasses and take a virtual reality through their heart or through their architecture from either a really good quality gated CT or MRI scan or a 3D TEE, not transthoracic echo. The quality's just not quite good enough yet. So in this patient, I'll pass this around because you can really see why he had TIAs and why he has brain fog and why he doesn't tolerate blood pressure medicine. So these are his carotids, which are nice and normal. This is his ascending aortic arch, which is nice and normal. And as it comes down, you can see there's an aneurysm right here. It's called a diverticulum of Commerell, but it's clearly an aneurysm. It's almost a ball sticking out. And we'll pass this around so you can look at it on your own. And you can see the size of this vessel here compared to the other vessels. So this is actually the blood vessel that goes to feed his arm. It should be the same size as its counterpart up here. It should taper down, so it should be a little bigger and then get smaller. But it actually comes off of the aneurysmal segment, and it's a nephritic vessel. And what happens to get blood flow to his arm is he steals blood flow from the vessel in the back of the brain, the vertebral. So when you lower his pressure, he gets dizzy, and he gets off balance, and he actually loses use of his left side, and he gets garbled speech. So what we've recommended to him is to take this and move it over to the carotid, so it comes off of the carotid, and then he'll get normal blood flow and resect the aneurysm so it doesn't continue to grow and rupture. So you can see why we would recommend that, exactly what it is. And again, for him, we don't want to skyrocket his blood pressure, but I also can't bring him to a normal blood pressure. So for example, right now, his blood pressure goal we have at 150/90, where that's too high for the long run, but for the short run, he's much safer at that level because we're protecting his cerebral perfusion. So I'll pass this around again. This is just a single color, simple arch. We are starting to do multicolor complex hearts, and we're learning a lot about them from things like this. So the technology, I think, is going to help and really advance care, advance our understanding and our collaborative relationships. And if anybody has questions, I'm happy to address them. Thank you.
Yeah, Dr. Fisher, thank you. That was fascinating. I totally believe that you are way ahead of your time.
Maybe not.
You know, if you guys want to hear a silly idea, this is something that a genius idea that I wish I could take credit for. But this is something that came up when I was having wine with Dr. Lasko. But there's a he was talking about the imbalance in the autonomic nervous system. So the autonomic nervous system it's sort of a yin and yang thing. You know, if you take a crocodile's nervous system really only has sympathetic and parasympathetic, and that's all the crocodile can do. The crocodile can only react to, you know, is it time to eat? Is it time to sleep? Is it time to run away? You know, the sympathetic nervous system is what makes you is when you're stressed out and there's danger and you gotta prepare your body to fight or to run away. The parasympathetic nervous system is when it's when things are safe. So, you know, you can relax, your blood pressure goes down, you sleep, it's after you eat. And so I think in a typical brain, these two systems are kind of balancing each other so that you're not too much one way or the other. Now, if you take EDS patients, if you guys kind of think about it, you guys are way too sympathetically overdriven, right? Your blood pressure can be too high. You know, you have all these blood pressure abnormalities. Your heart rate's always racing. Your pupils are always large, right? These are all signs of sympathetic overdrive. And if you take a brain and a body that's sympathetically overdriven all the time, this can lead to chronic changes in your blood vessels. And you can make the blood vessels can become more stiff. And if for example, if you take the brain where this lymphatic system is very dependent on blood vessels bouncing and jiggling like normal, if your blood vessels are sympathetically overdriven, that can potentially break that system and cause your brain to not be able to clean itself. Now you might think, well, you know, what is it about EDS that causes this imbalance? Well, if you think about it, you know, you guys are put together a little bit more loose than the rest of us, and that stresses out the body, right? That stresses out the brain when it's spending its entire life trying to hold everything together. You know, it always puzzled me why, you know, someone comes in with brain fog, they get a cervical fusion, and that brain fog goes away. Like, that just neurologically doesn't make sense to me. But if you take away all that stress and the brain's able to kind of relax again, and there's more of this imbalance, there's more of a balance between the sympathetic and the parasympathetics, then I think that all of a sudden makes more sense. So, you know, part of the issue could be that EDS people are just, there's too much sympathetic drive, and if we can somehow balance that a little bit better, then maybe a lot of these problems may just fix themselves.
So this may be a very simple way to look at that, but I kind of think of your patients as having brainstorm that affects my vessels and heart rate. Because, you know, it's a very dramatic response that when you have the brain uncomfortable, you have a lot of sort of give back where it's trying to regulate everything. And the brain actually has the power to regulate everything, right? And it has ways to talk to the blood vessels that we do and that we don't understand. So we can measure things like adrenaline, we can measure things like norepinephrine or epinephrine, but we don't know how to measure these neurotransmitters. And we don't know how to measure or upregulate or downregulate some of the vessel receptors that actually tell the vessels to dilate or constrict, or to kind of turn off the response to the brain and listen to everything else. Because really the primary effect of the body is to maintain blood flow to the brain. So if the brain's not getting enough blood flow, it's going to make somebody go down so that it can get enough blood flow. And the only way to really address that is to address the brain. I am also hoping, however, that things like venodilator medications may be better tolerated, because the veins are distensible, right? And if your pressure is low, if the volume's low, you're going to have them collapse because they're collapsible vessels. So how, without permanent materials, can we get better results? You know, what kind of medications would cross the blood-brain barrier and actually allow venous dilation without so much of the, without worsening the dilation in the lower body? So that's what would help Nassau too, is if you had something that actually affected the blood vessels in the brain, but didn't distend the blood vessels in the rest of the body. So a barrier selective venodilator is my wish.
We'll be rich in fins.
Yeah.
I have a question from one of our WebExers. What symptoms do you hear patients report with feeling terrible with a narrow pulse pressure?
People describe lightheadedness, jitteriness, dizziness, rapid heartbeats. And again, it's a measurable number, so you can tell if that's what it is by checking your blood pressure. And if the top and bottom number are too close together, when you feel that way, you probably need to address that first with salt and water and compression, because you really need to fill the heart. So you need to get all the blood flow back from the vessels back up into the heart, fill the heart, and then the heart can do what it needs to do and pump the blood to the lungs and then out to the body.
Is there a replacement that you tell us once you restore volume? Can you give digoxin or digitalize the heart to increase the inotropism?
Well, you can, except that in these patients, the heart function, the systolic, at least the measurable and visible systolic and diastolic function is not abnormal. It's not a primary heart issue, and a lot of times the heart is just underfilled. So you really don't want to use medications that affect the inotropy if the heart's underfilled. So you could, but I don't think you'd get a good long-term effect. You have to fix the filling.
Can you get the low pulse pressure if the filling, if the volume is normal, and what are the causes of low pulse pressure then? Would that be?
So the real only causes that have been described are low function, which is where I think the thoughts are coming from, but we can see that with the echo, and we can see that with response to stress, or sometimes we'll do things like stress echo to see does the heart have normal reserve or doesn't have normal reserve. So those are measurable things. So, you know, there's not a lot of other causes of low pulse pressure except just poor output, poor volume. So you can either have a really low heart rate and a normal volume, which again you could see, or you could have a normal to high heart rate but not enough volume to not get enough out, or you could have poor function. But treating poor function when the function's hyperdynamic won't get us anywhere. So in the patients that we've been seeing, the function is really great, but the volume and the pooling changes. So these patients feel bad when they're upright, but they feel okay laying down. When you look at their function in any position, it's actually really good. But you'll see actually the pooling. And last time I was here, I showed some of the distended veins that we're seeing with spontaneous contrast. So a lot of times when we do regular echo, we'll see dilated inferior vena cava with spontaneous echo contrast, which goes with a low flow state. So the flow into the heart is low. And that's where I think people are getting this lower output. We haven't directly measured things like cardiac output when people change position. It would be an invasive measurement. There are monitors. There's something called a Vigileo, but I don't think it's actually correlates very well. It's very accurate where it would be worth doing that type of study. And an invasive study, you know, would be probably more risk than benefit. So it's a hard, I think that's why the question's not answered yet. Yeah. But it's clear, you know, and people who've been doing home blood pressure monitoring have realized this. Also, with all of the heart rate and blood pressure monitoring that's becoming available with technology, we're really learning a lot from that. We're learning where there might be arrhythmias, where people are feeling their arrhythmias. Some people can actually feel all these heartbeats and extra heartbeats, and some people don't feel anything. But they're still having them, and they're still affecting them. So sometimes these gadgets are actually really helping pick out the problem in a particular person. So if you can't tell and you're getting these strange changes in the way that you're feeling, sometimes something like a heart rate monitor or an Apple Watch, it can make a big difference in figuring out what you're feeling. And maybe that's actually not an issue at all, and it's okay to go on to something else. Or maybe it actually shows up that that's your primary issue, and some of the directed medications can actually make you feel so much better, like beta blockers, that, that you can actually function again. So.
Have you studied at all how mast cell dysfunction affects orthostatic intolerance?
I have not, but I have definitely seen some patients who do remarkably better when their mast cell disease is treated or addressed, or the allergens removed, or they're in better situations. Or sometimes with cromolyn. But I've certainly seen people function and do remarkably better. I certainly have not formally studied that. And it would be out of my realm.
A lot of the mast cell docs are really finding a correlation, though, with the rapid heartbeat and getting it under control. And I know personally, and I know a lot of people in the group, that also their tachycardia calms down when their mast cell is more under control.
I've definitely seen remarkable benefits in people that are treated too, and I think if somebody really has mast cell issues, the treatments work, and if the treatments don't work, the treatments are very effective to stabilize mast cells in general. So outside of like a malignant mastocytosis, it's a controllable problem, so you can actually treat it and see how somebody's doing, and then remeasure the effects on the heart rate and blood pressure. And a lot of people can come off of some of their POTS medications, can function better, and can do a lot better if that's the problem. It's not the problem for everybody, though.
One of your slides said that giving vasoconstrictors makes dysautonomia worse. One of your slides that you showed in the beginning, did I read it correctly or did I not?
I don't think so. So I didn't really talk a lot about the treatments, except in one that had treatments, which had some of the vasoconstrictors. There is one type of dysautonomia, which would be the higher adrenergic state, and it certainly would make that worse. I did talk about vasoconstriction of the vessels being part of dysautonomia, vasodilation or vasoconstriction. Yeah, so vasoconstrictors are used very, very well actually when there's vasodilation. That's the reason for the low blood pressure or fainting. So if you have vasodilation, especially of the arteries, the vasoconstrictors work really well. The veins are less easy to influence. They're actually easier to dilate, at least peripherally. We have a lot of venodilators for peripheral disease that if we use them in this population would make things worse because they'll increase pooling, but certainly can open up veins in the periphery. We don't have a ton of venoconstrictors that make the veins get stronger. So things like mitidrin is not a direct venoconstrictor. It's not directly making the veins smaller. It has a bigger effect on the arteries than it does on the veins.
It's an issue that you as my doctor know about, but I'll share is like when I have anesthesia and my blood pressure and heart rate go really low, they want to give me adrenaline or phenylephrine or something, and that it only helps for a second, and then I have the crash afterwards, and I would tell them don't give me that because it's going to make it worse. And sure enough, if you get my stuff, it makes it worse every single time. And when they finally get smart and stop giving it to me and just wait it out, everything just evens out.
Right, and
because I'm a redhead that I need.
No, but again, that's true for you, but not for most Ehlers-Danlos or POTS patients. So there's a whole world of personalized genetics where we're trying to look at how people metabolize agents like psychiatric drugs like like stimulants and like anesthetics and pain medications. So,
It's dysautonomia, you have it, you're.
but that is something that you've seen for you and has been repeatable, but is not for most people. And for most people with vasodilator problems, that phenylephrine is exactly the right drug to use and can be life-saving to use it. So we don't want to take that off the table because that's exactly what most people need. And again, that's where sometimes if you have adverse reactions to medications, working with genetics, a genetic doctor who can actually do some of the testing for how you metabolize medications can be really, really helpful. And then you can take that to different physicians saying, if you need to treat me with medications, here's how I metabolize things. At least let's start with this, and really write out, like you do, but not everybody does, write out a list of the things you've tried or had adverse reactions to so that you're starting at a higher platform, and then you're protecting yourself from having the same problems over and over and over again.
It just doesn't work if they don't listen to you.
Yeah, so again, things like having an anesthesia meeting with the anesthesiologist ahead of time if you've had adverse reactions. And I know you're a great advocate and have done that.
I know that too, it just doesn't work.
But in general, it usually can work. It should be able to work. And hopefully you don't need any procedures, but if you do, again, that pre-anesthesia meeting and having the information with you can really elevate the level of your care. And it can also make people realize that just because you look young and beautiful and redhead, you still need extra monitoring and support. You may need a little bit longer on the monitor. It may be better to do your procedure in a hospital-based setting. It may be better to have a more experienced anesthesiologist.
A lot of people don't understand pharmacogenetics, is what someone
Right.
at the hospital told me. Oh, you gotta really explain it to them. I'm like,
Right, but sometimes if you have your report from the genetics companies and you just say, look, I don't metabolize these things normally, my doctor asked me to share this with you, it can be received a lot, Yeah, I actually think it's incredibly helpful and protective if you've had this type of reaction to actually protect yourself going forward.
I gotta listen.
Because again, that's different than probably everybody else in the room. And it is very, very important, but it's not something that should change the way they care for other people. It should only change the way they're caring for you. And again, I think that this problem, and why I wanted to start with so many types of collagen, this is a very personalized problem because, again, it's not only the type of collagen, where in this room there's probably people with 5, 10, 20, 30 different types of collagen issues. Right, and then you're looking at other issues that make that worse or better than they might have been in the person next to them had it been the same gene. Yeah, and you can see that in a family.
Any other questions? So let's thank Dr. Fisher. Dr. Liu. Thank you all for coming tonight. Please take a brochure. Please go home and put yourself in the registry or your family member. It's very important. And our next meeting is going to be in October. It's not up on the website yet. I believe it's October 24th at Johns Hopkins because we're alternating between the two hospitals. And then we'll be back here in January. So thank you all for coming and hope to see you soon. Have a great night.